Earle. We're here at Pure Plastic Surgery today, and it's Hump Day with Dr. Earle. All right, so as you guys, or many of you know, this is the time that we get to spend with each other. I get to go over some plastic surgery topics, and of course, happy to answer any and all of your questions regarding to plastic surgery. Okay. As usual, I like to start off with a specific topic. So we're going to talk about something here today regarding BBLs. But after that, I'll be happy to answer questions regarding any plastic surgery topic that you may have. Okay. But today I wanted to talk about something that's actually come up fairly recently. This has come up in our Facebook group and some other Instagram and things like that. And it has to do with BBL and how it relates to cellulite, dents, okay, and also flat spots. All right. And it's a little bit of a controversial topic, not really just in the sense that a lot of times patients don't like the response or the answer that you're giving them. And I feel that of course one of the reasons we do the hump days is because I want to educate our patients so they know what to expect. So typically, if the patient is educated, if the patient knows what to expect, then there's not so much being mad or animosity when something doesn't come out the way that they expected after surgery. Okay, because one of the things that a lot of patients complain about when they want to have a BBL is that they have these areas, these like small dimples or divots, and they say, "Doc, I want to get these areas filled out." And a lot of the times, most of the time, the reason for that is cellulite. So cellulite in women and adult women is very, very common. I've seen studies where it says that it can be up to 90% of women that have cellulite at some point in their lives. Okay, so extremely common. And of course, a lot of women don't like it, and they feel insecure about it. And sometimes, if they have a fairly moderate to severe cellulite, it can be seen through clothes and, of course, in their swimsuits. Unfortunately, up to this day, there's really not a great cure for cellulite. If we had that magical cure, believe me, everyone would be doing it. But unfortunately, we don't have that just now. But one of the misconceptions out there is that whether a BBL or liposuction with fat transfer can cure cellulite. Okay, and the short answer is no. Okay, so BBL is not necessarily a cure for cellulite. In most cases, the cellulite remains very, very similar to where you started. There are some cases where it does improve. In most cases, I would say it remains similar. And I've even had a couple, not many, but a handful of cases where it actually got worse. Okay, and so let's kind of jump back a little bit. So what is cellulite? Why does that happen? So cellulite is actually because you have these kind of attachments that go from the muscle, the gluteus muscle, through the fat, and then attaching to the skin. Okay, and so they're called fibrous septae. Okay, and so some of those attachments kind of become short, and they dimple the skin in that area. Okay, and so when we do just BBL, when we're doing fat transfer, we're not necessarily doing anything drastic to those septae, and so that's why even though at the beginning things may look better because there's a lot of swelling and everything else, after about 3 months, once all that swelling's come down, once you've lost some of the fat that we transfer, as you all know, we lose about 30% of the fat, then that cellulite may reappear. So short answer, once again, is BBL a cure for cellulite? The answer is no. There are many times where the patient may not notice or may not see that she has cellulite, and then of course after BBL, she's a lot more conscious about how the buttock is looking. She's looking at it every day, she's taking photos, and all of a sudden, there's a complaint like, hey, there's a dent here, I never had it before. And then you go to your pre-op photos and you can see that yes, the cellulite was there before, their little dimple was there before, and like I said, a BBL is not a cure for cellulite. So what is a cure for cellulite? Like I said, there's no complete cure, but there are two options where you can improve it or at least make it better. Okay, and the two options right now are, one is called Selfina. Okay, and that's where you're actually kind of physically, mechanically breaking up some of these fibrous septae, okay? And the other option, which just came out, is called QWO, Q-W-O, okay? And that's actually an injection where you inject it into that cellulite dimple, okay? And it breaks up like through enzymes, okay? So like an enzymatic breakup of those fibrous septae that cause the cellulite, okay? So here at Pure Plastic Surgery, we currently, we don't have sulfina, and we're definitely in the process of getting certified to use QWO. It's very, very exciting. Like I said, it's relatively new. I heard about it a couple weeks ago at the aesthetic meeting, so we're getting geared up to get trained on that and to then be able to offer it to our patients. Now, the one caveat to that, and it may be tough for a lot of our out-of-town patients because it does typically require 3 treatments. So it is tough to for optimal results. So it may be tough to kind of go back and forth. However, there is a very significant improvement after only 1 treatment. But I want, stay tuned. We're going to learn a lot more about QWO. I'm probably going to give a talk, totally dedicated to QWO in the next couple of weeks or so.
How long does QWO last? Quick question.
So once you go through the treatments, it should essentially last forever, as long as there's no big fluctuations in weight, okay? Or any huge hormonal changes, like say for example pregnancy. All right, so if your weight's pretty stable, your diet, your exercise, your nutritional status, then it should last a long time. Okay. All right. So that is as it pertains to cellulite. Now, of course, there can be other dents, okay, that can be due to other reasons. So, say some of the most common ones we see are due to prior injections. So, a lot of vaccinations when you're a kid can sometimes cause scarring, which can cause a dent, okay, or trauma. I've seen that as well. So I've actually had a few patients where they've had their BBL and then unfortunately fell under buttock, had a hematoma, and that eventually led to scarring and a dent. Okay. Now it's different as to what exactly is causing the attachments, but the concept is very similar. But now instead of having fibrous septae that are causing these attachments and causing the dent, what you have is actual true scarring. Okay, scar tissue. All right, and again, so that scar tissue needs you need to try to break up that scar tissue before you can then fill it with fat. The issue with that is that you cannot be overly aggressive. Same with like the blunt objects we're using in the BBL for cellulite, with dents as well. If you're overly aggressive, okay, and you break up that scar tissue too much, then you can have the opposite effect. You can have what's called a blowout deformity, okay? When you have a blowout deformity, you go from a dent, okay? You go from that dent to a blowout, okay? And that is much worse. You don't want to have a blowout deformity. Why? Because it looks terrible, okay? That is really hard to hide in clothes because it pops out. And then if you put fat in there, the fat just kind of sits there like a pool. It's almost impossible for it to get vascularized. And so one or two things, or a few things could happen. It can get infected. It can form just like a fat cyst, or it can form fat necrosis. Okay? So all these kind of negative things can happen if you have a blowout. Okay? And so that's kind of similar to what happens with flat spots. Now, flat spots are controversial, right? They're controversial because a lot of times, the patient is upset that they have a flat spot and they blame the surgeon and say the surgeon caused the flat spot. And honestly, most of the time that is not true. It's typically a pre-existing flat spot that you only notice more afterwards, okay? And so what causes a flat spot, it's a similar concept. You have these ligamentous attachments, okay, that attach from the muscle through the fat, okay, and then it makes it flat in a certain area. So you have ligamentous attachments through the muscle to the fat, creating that flat area, okay. So again, you can ask the question, why don't you just break them up? Why don't you just basically cut all those attachments, okay? And the issue is exactly what I talked about. If you do that and you're too aggressive, you're gonna go from a flat spot to a blowout, okay? And when you go to a blowout, that's really, really a bad place to be. It's extremely difficult to fix a blowout, number one. Number two, it's a much higher chance of it getting infected because you have that pool of fat just sitting there with no blood supply. So even if it started to get infected and you gave someone IV antibiotics or oral antibiotics, the antibiotics can't get there. So a lot of the times then you have to do what's called an incision and drainage. You have to make an incision in the skin here and drain out that pool of fat, okay? So it does really cause a problem. So that's why, you know, the prudent surgeon, the safe surgeon, would not be overly aggressive. And then every patient is different. There are certain patients where we can actually get it to stretch, okay? And then we can turn the flat spot into a more rounded contour. And then there's patients where it just won't budge, you know? And it's very frustrating. Of course, it's frustrating for the patient and it's frustrating for the surgeon too. So the best thing that you can try to do when you get that type of patient is to try to camouflage the flat spot. What does that mean? That means you try to fat graft kind of around the area in order to try to create, you basically make it less obvious, okay? And that's what we try to do here. So when you have a flat spot, first step, try to see if you can raise it. If you can raise it, great, awesome. And if you can't, then you try to basically try to fat graft around the area, try to camouflage that flat spot, try to make it less obvious. Okay, so that's essentially these three things in a nutshell. So I'll be happy to take any questions regarding that.
Will you perform this to anybody over 50 years old?
A BBL?
A BBL, abdominoplasty, or a breast procedure?
Okay, so for BBL, the age limit is 50. Okay, it's a big surgery. It is a tough recovery. So we put the age limit there at 50. But for mommy makeovers, tummy tucks, everything else, the age limit is a bit higher at 55.
And do you have an idea when the quo will be ready?
I don't have an idea just yet. So we contacted the rep, and so we gotta go through a little training, and then it should be available. But I anticipate it shouldn't be much more than say 2-3 weeks or so.
Okay, just a few more questions on quo.
Yeah.
Can quo be used for inner thighs fat reduction?
So it is FDA approved, but as of right now, it's only FDA approved for the buttock. Okay, so there's probably doing more research. I'm sure they'll expand to other areas in the near future, but as of right now, it's for moderate to severe cellulite of the buttock.
Are we allowed to get surgery after the COVID vaccine?
Of course, yeah. So certainly you can get surgery after. There aren't any strict guidelines as of yet. So what we've been doing here at Pure is that we've had our patients wait about 30 days after they get the COVID vaccine just to make sure that they're fully recovered, they don't have any undue effects, and that they're doing well, and that the vaccine has had a chance to work, right? Because you don't just get the vaccine and the next day you're immune. Okay, as you know, for a lot of them there's 2 doses, right? Spread 3 weeks apart, and then it takes about 2 weeks from that second dose to achieve immunity, okay? So if you had your vaccine, your final vaccine, then we can wait about 30 days, and then you should have immunity, and you should be good to go.
And a 2-part question, is your BMI, does it still apply to quo?
No, there's no, it's not a surgery, so the reason why we don't accept, say, higher BMIs and surgery, especially under general anesthesia, is because the risks and complications go up, okay? But quo is an in-office procedure. It doesn't require any anesthesia whatsoever. You're just doing it basically in the clinic. Can be done by a physician, by a nurse practitioner, and that's something that where the BMI status doesn't really matter there.
And to other surgeries, how strict are you on your BMI if somebody's, let's say, 1 over?
So we're fairly strict, okay. We want our patients to be BMI 30 or below. If you're pretty close, then typically we do go ahead and quote you and we can reserve a date. But if you're far from that BMI target, then it's best to just go ahead and lose the weight, try to get closer to that BMI target, and then we can go ahead and quote and basically save the date for you. But we want to make sure that, you know, when you get to your surgery date that you're at your goal, because we don't want to be canceling anyone last minute. And that's not good for you. You've traveled all the way from, you know, another state and you've made all these arrangements. And it's not good for us, of course. You know, you know, we're very, very full, so we want to make sure that everyone who comes here is able to have their surgery and not have you know, an opening in the schedule.
Can you still get lipo and a BBL if you have fibroids and ovarian cyst?
Yeah, so that really shouldn't be a problem. So remember, liposuction is between the abdominal wall or the muscles and the skin, okay? And so your uterus, your fibroids, your ovaries, and all that is quite deep to that. So unless, you know, there's these huge fibroids, sometimes women can have like super large fibroids, but, you know, barring anything like that, it's not a problem.
Hi, doctor. What's the least invasive procedure to sculpt my body fat? I'm scared of a BBL.
The least invasive
that you offer, you would.
You know, it's pretty much BBL is really the best one. You know, the best procedure for sculpting the body. It's the most powerful procedure for sculpting the body because you're combining the liposuction aspect, okay, and where you're subtracting and then you're adding. So it's like subtraction addition. You're subtracting in the areas you don't want, you're adding to the areas that you do want, and that can really, really, you know, change and contour the body in a very powerful way. You know, if you have like small areas that just need a little filling, you know, the less invasive option or the non-surgical option is called Sculptra. But Sculptra really only works for small areas, and unfortunately, you know, the injections are can get very expensive quite quickly, and it doesn't last forever. Typically, it lasts about 2 years or so.
Can body tight be combined with Quo?
So no, I wouldn't do those things at the same time. So that's a good question though. Like I wouldn't do Quo at the same time as your BBL. This has to be at a totally separate time. So you can do it before your BBL or after you're healed after the BBL. I probably recommend to do it after to see where everything kind of ends up. So after you're completely healed from your BBL, if that cellulite, those cellulite areas are still there, then you can go ahead and do the Quo treatment.
Hi, Dr. Earle. After having a C-section, how long do I have to wait to get a BBL?
So you want to wait at least 6 months, okay? You want to make sure, of course, you're fully healed from your C-section, but you also want your body to kind of come back to baseline. And that's going to take at least 6 months after having your C-section.
We have a few questions about the cellulite at the top. Can you just address that again with the BBL and the Quo? With the
just like a quick summary?
Yes, please.
All right, quick summary. So, is a BBL a cure for cellulite? The answer is no. Okay, BBL is not a cure for cellulite. Okay, so if you have cellulite and you have a BBL, you'll very likely have the cellulite again. What happens though is that, you know, you guys remember the emotional roller coaster? What happens is there's a couple of things that happen. One is at the beginning you may not even notice you have cellulite because you're not looking at yourself in the buttock, you know, that often until after you have your BBL, and then you're really looking. And then, you know, shortly after the BBL, there's, you know, all this swelling that's going on. And so the cellulite may look like it's disappeared, but it really hasn't. And then, say about 3 months, you know, post-op, once all that swelling's come down, once you lost your whatever 20 or 30% of the fat that you're going to lose, the cellulite reappears. Okay, and that's when you have the patients upset and saying, oh, look at this dent, I never had this dent before. And then, of course, you look at your pre-op photos and it was there the entire time. Because, like I said, BBL is not a cure for cellulite, okay? What does help with cellulite, I wouldn't say it's a complete cure, but what can improve it, what can make it better, are the two options we just mentioned, Sulfina and Quo. And Quo is the one that we're looking into having here at Pure Plastic Surgery.
Thank you very much. I had my BBL last October. My BMI was 32. Do I need to get down to 30 for my second round?
Ideally, yes. We're a little bit more lenient with those that were our patients already, you know, our second round with us. But really, yes, you should try to get down to your BMI of 30.
What about a BBL for somebody who has a history of small bowel obstruction?
Okay, I mean, it depends, I guess, what your status is, right? So if you know, you you had a history of small bowel obstruction, you had your surgery, they removed the segment or whatever needed to be done, and now you're doing okay, and you have no digestive issues or absorption issues, then it should be okay. But of course, we're going to need the clearance from your medical doctor to make sure that you're doing well now and that you can go through another surgery. Okay.
Thank you very much. Can you explain a little bit about Body Tight, please?
Body Tight, yeah. So Body Tight is a machine basically that we have that is helpful in allowing the skin to contract. Okay, so how does it work? Well, it uses a special type of energy. It's called radio frequency energy, and it imparts that energy onto the skin. It basically heats up the skin from the inside. Okay, and that then causes an inflammatory reaction, which causes that skin to then want to shrink back down or contract back down. Okay, so Body Tight is the one that we have here at Pure. The other one that's very similar, you may have heard of, is called J Plasma. They both use the same type of energies, radio frequency energy, and the mechanism is basically heating up that skin and then allowing it to contract.
Thank you. Will my surgery be canceled if I'm at a 21 BMI and your minimum is 22?
You're probably talking specifically about BBL because that's pretty much the only surgery we have a minimum BMI for. And not necessarily. I mean, that we can take on a case-by-case basis. BMI, two people with a BMI of 21 may look very, very different. So it really depends on how much fat I think is available, and of course also what the goals of the patient, what are the patient's goals. So if they want, just some, maybe like an enhanced natural look, some more subtle changes, then typically we can go ahead and do that. If they're looking for a bit more of a drastic difference, then perhaps it is prudent to try to gain the weight and then come back, so that you can try to get as much done in the first round as opposed to having to come back for multiple rounds because there wasn't enough fat for what we needed to do.
The next question, do you add drains in post-op for BBL or breast augmentation?
So no drains for breasts. I usually don't use drains for almost any breast procedure nowadays. I do use a drain for lipo 360 and BBL, and of course we use drains for tummy tucks as well.
What are the complications of having a higher BMI, such as, let's say, 35 to 40?
Right. So if your BMI is 30 or above, you're considered, according to the American Medical Association, you're considered to be obese. And if you're above 35, you're considered to be morbidly obese. Okay, and the risk of complications with surgery go up as your BMI goes up. So the risk of blood clots goes up significantly. So either blood clots that can form in the legs, those are the deep vein thrombosis or DVTs, and also the risk of the blood clot in the lung. That's called a pulmonary embolus. Okay, so the risk for blood clots goes way up. Risk for infection is higher. The risk for wound healing problems is higher. Okay, so more chance of open wounds, having to deal with open wounds and having them heal slowly over weeks and weeks, or potentially needing a wound vac or something like that after surgery. Okay, so yes, so certainly the risks of general anesthesia also go up. Okay, so having a high BMI, especially if you're in that morbidly obese range, so that means 35 or higher, that puts you at a pretty high risk with general anesthesia, and it's just not prudent to do an elective surgery in an office-based surgery setting with a BMI that high.
Can you perform a BBL with somebody who has sciatica nerve pain?
You certainly can. So the sciatic nerve, of course, runs deeper to where you would be doing the fat grafting. So once again, so nowadays we do the fat grafting in that safe zone, which is basically in that superficial fat space between the muscle and the skin. Okay, the sciatic nerve is going to be actually deep to that muscle, so you're not going to be near the sciatic nerve. Now, can it cause or exacerbate your sciatica, especially initially? It is possible because, of course, there's going to be swelling, and then, of course, the fact that you have to be laying on your belly and things like that, it can potentially exacerbate your sciatica temporarily. while you're going through your recovery.
Thank you. What if your patient has a high BMI with mostly muscle mass instead of fat mass? Will they be eligible to get surgery?
So that would have to be taken on a very, very case-by-case basis, okay? And we'd have to see, exactly, how much muscle mass there is, basically. What I can tell you, anything that's 35 or higher, doesn't matter what type of kind of physical constitution you have, it's probably not going to happen. If you're between 30 and 34 and you feel that it's mostly due to muscle, then of course we would have to do that evaluation, like I said, on a case-by-case basis.
I'm 3 weeks post BBL. How long after should I wait for quo?
You want to wait at least 3 months, right? So you want to do a full recovery. So we always say with the BBL, you're not going to really see more final results at least 3 months out. You're not going to really see enough kind of shrinkage in the swelling and everything else at least 3 months out, and we're not going to know how much fat survived, how much fat died, really ultimately to about at least 3 months out. So I definitely wouldn't do it before 3 months.
All right, next question. Is quo something that destroys something inside?
Yeah.
Or is it similar to filler that stays?
No. So the first one. So when you have it's like we said kind of at the beginning of the talk here, what causes the dimpling for the cellulite, they're called they're these septae, okay, and these these little, you can think of them like little anchors, okay, that are attaching the skin to the muscle. They go through the fat, from the muscle through the fat up to the skin, okay. All right, and so the quo is an enzymatic. It's an enzyme that breaks down these septae and therefore releases them, and so then that anchor that you had now gets released, and the skin is allowed to basically pop back up to where it should be. So it's not a filler. It's actually more like an enzyme that breaks up these septae.
Thank you for that. How many massages are needed after the BBL?
All right, so typically I've always been saying that the minimum amount is 10, and that really is like strictly the bare minimum, okay? 15, 20, 25 is not unusual. So if you really want to optimize your results, I would probably shoot for 20 and then see where you're at. I would definitely budget for at least 20, okay? And then you can then see where you're at, see if you require any more after that.
Do you use ultrasound for all your BBLs, or is that an extra cost?
It's not an extra cost. It's used for all BBLs, and it's used while I'm doing the transfer to what we call the danger zone. So it's a very specific area where the ultrasound is being used. So in that, from the midline to about somewhere about 10 to 12 centimeters to either side, that's what I'm calling the danger zone. Deep to that area, when you go deep, that's where you have the superior and inferior gluteal vessels. Those are the ones that you want to avoid, and therefore the ultrasound is used in that zone to make sure that the tip of the cannula is in that subcutaneous space between the muscle and the skin. We're going to graft the fat or transfer the fat into that area safely. And then once you go lateral to that, so beyond 12 centimeters out to the side, like lateral buttock and the hip area, there's no big vessels there. There's really not any danger there. So the ultrasound's really not needed, and that's just done with your regular kind of technique.
Do you have to avoid sitting on your butt after quo?
Good question. Actually, I'm not quite sure. So that's why we haven't launched it yet. I don't have all the details, and that's why as soon as I do, I'm probably going to do one of these hump days dedicated fully to quo, so that we can show you all the details regarding the exact mechanism of action, exactly what it does, how many treatments you need, and what the post-op care would be. Okay?
Why do some people need a second round BBL?
So there's multiple reasons. So okay, say if they didn't have enough fat, they may need a second round to add some more projection. Okay, say they had pretty severe hip dips. The fat in the hips doesn't always survive, so maybe not all the fat survived, then they want to go again to try to fill that area out again. Say it's the other end of the spectrum. Say the BMI is on the high side, we took out 4 liters, which is the max that we can do here in Florida, but there's some fat left behind, so they want to have a second round there. Say you want an extreme vixen look. It's very difficult to do an extreme vixen look safely in one round, and safely is the key there. Yeah, you can go to Mexico or somewhere else and they can put a whole bunch of fat in your muscle, but potentially you can get a fat embolism and die, right? That's the risk that you're going to take. So you want to be safe, you want to stay in that subcutaneous space, so you only have that one space to expand. So if you're looking for an extreme mix and look, it's going to take more than one round to try to achieve that look.
Thank you. I'm afraid to be put to sleep. Do you do any awake lipo?
I don't. I don't like to do awake lipo for a few reasons. One, when you do awake lipo, that means that your infiltration or tumescent fluid has to have lidocaine, okay? And you know, it happens rarely, but it can happen. There's such a thing as lidocaine toxicity. If there's too much lidocaine for the body to handle, it becomes toxic to the body, and that can cause neurological and cardiac issues that can be quite severe. So when you do it on general anesthesia, you don't have to use lidocaine at all, and that's what we do here. I never use any lidocaine in my infiltration fluid, and therefore the risk of lidocaine toxicity is zero. Then the next thing is in terms of just trying to be aggressive enough to really try to achieve the look and the contour that we're looking for. It's very difficult to do that with the patient awake. No matter how much numbing tumescent fluid there is, how much sedation that you can give without putting the patient too much to sleep, it's just very, very uncomfortable, and a lot of times there's a lot of complaining, there's some movement, and you're not able to achieve the result that you want because of that.
Thank you. Just to stay on that topic of anesthesia, we have a few questions. Some people, I'm sure you've heard that a lot, people are afraid to be put to sleep.
Sure.
So how common are complications, and what typically causes complications from anesthesia?
So we're talking about just potential complications from general anesthesia alone.
Yes.
The complication rate is very, very low. It's quite rare, especially for the type of patients that we do here in an office-based surgery setting. So we're dealing with typically young, healthy patients, right? So 50 or younger, so young patients with minimal to no other medical problems or comorbidities. And if they do have something like, say, for example, high blood pressure, it's controlled. So this is, okay, so these are very highly selected patients that we know that are young, that we know that are healthy, and therefore the risk of general anesthesia is extremely, extremely low. It's not the same as, say, if someone, in a hospital setting that's 80 years old and going for a major cardiac surgery, okay? That's a completely different, risk factor there.
Thank you very much. I know we're pushing your time here. Let's try to get to a few questions.
Okay.
Can you do a tummy tuck and a thigh lift at the same time?
You can. Yeah, I mean, theoretically you can. I don't like to do that, okay? But theoretically you can, because they're both surgical procedures, so you can combine surgical procedures. The most common combination of the tummy tuck, of course, is a breast procedure. That's what we call the mommy makeover. So whether it's a breast aug or breast lift with implants, you can combine that with a tummy tuck. That's pretty common. Sometimes you combine that with a brachioplasty or arm lift as well. Usually when I'm doing a thigh lift, I kind of like to do that on its own, okay? It is a tough surgery to recover from because those wounds and we're always kind of moving around, the legs are always moving, the incisions go up into the groin area, which is an area that is difficult to keep dry, and so it is a tough recovery in that sense. Sometimes you can have some wound breakdown, you may have some wounds that need to be taken care of once the dry dressing changes, things of that nature. So for all those reasons, I typically like to do a thigh lift on its own.
Can you use XBRL with any other procedure besides a tummy tuck?
You can use it for surgical procedures, okay? So it doesn't work well for lipo type procedures, so not for lipo 360 or BBL. But you can use it for anything that requires a long incision. So yes, definitely the tummy tuck is the one that we most commonly use it for, because we can also put it in, along that muscle repair, and then of course along the very long incision that goes from hip to hip. If you wanted to, you could use it, say, for example, for a breast reduction or a breast lift, especially when you're doing that upside down T or anchor type pattern, and it can help there as well. And say an arm lift or a thigh lift, you can use it for that as well. You wouldn't want to use it for something with a short incision like a breast aug. It's just not worth it, I would say, in that case.
Thank you very much. For the last question, what is this about Twilight anesthesia that I hear other people are doing? Can you explain, please?
Yeah, so Twilight is not general anesthesia. So Twilight is when you're combining local anesthesia, which means you're using something like that tumescent fluid with the lidocaine, and patient, you're giving some sedation through the IV, okay? So the patient is, sedated. The patient is not really conscious of what's going on, but the patient is not completely out. They're breathing on their own, okay? That's the difference between Twilight and general anesthesia. In general anesthesia, the patient is completely anesthetized. They're completely out. They're not breathing on their own. We put the ET tube, we hook them up to the machine, to the ventilator, okay, and the machine's helping them essentially breathe throughout the case. The patient's totally paralyzed, okay. But with the Twilight, patients breathing on their own, and potentially that's when you hear more commonly like, oh, I woke up in the middle of my surgery, type of things. That's more common with a Twilight anesthesia and almost never happens with general anesthesia.
Thank you, Dr. Earle.
All right.
Yes.
Okay, everybody. Awesome. Well, I hope this was very, very helpful. I know a lot of you are in our Facebook group, Earle's Pearls. So in that group, I put up several posts, and I recently put one up regarding cellulite. Pretty soon I'm going to put one up regarding flat spots, okay? And we put in a lot of great information there to educate you guys, to educate our patients, okay? But I look forward to seeing you all next week on